And so when you have the patient coming in who does not have a diagnosis of OSA, let's say it is that classic patient that's coming in with their partner and fix the snoring and they're falling asleep in the afternoon, it seems like there may be an issue. Now that you're paying attention more to the nose, as we're kind of unpacking this nasal obstruction part of it, are you asking more questions about nasal obstruction and allergies and runny nose and that sort of thing when you're taking that initial history?
I really am. And Ashwin, your comment earlier was spot on. I mean, this should be a part of every patient that we see. And it is to some extent, but I think, Ashley, I'm taking much more care to ask even about postnasal drip, rhinitis, congestion, those maybe traditional allergy symptoms, because those also negatively affect sleep quality. So absolutely, I'm trying to, essentially, as we should all do, ask all these quality of life questions, and that helps us formulate our recommendation for the patient.
Yeah. My initial sleep history I see a lot of I see like probably 10 patients per day who are new patients referred from primary care for sleep medicine, not necessarily for an ENT evaluation, just, hey, new onset AFib or snoring, choking, gasping, or falling asleep at work or Department of Transportation physical. My history is really just a sleep history. What time do you go to bed? How long does it take you to fall asleep? Are you waking up a lot at night? What time do you wake up? Any medications associated with that? Are you falling asleep during the day? And then just when I'm examining the patient, I say, do you have trouble breathing through your nose? And then I look in their nose. And I guess the kind of unpacking that, my goal is not to do a septoplasty on every OSA patient. My goal is to get those people treated. But yeah, the nose is super important. So it's not a huge focus of my initial history, but it is a huge focus of my history on a CPAP intolerant patient, especially when they say that the pressure was not, they weren't tolerating the pressure. So I think that pressure intolerance with the CPAP is a huge harbinger of nasal obstruction as the cause.
Absolutely.
So if people say, I can't tolerate my CPAP, can't handle it, we should be thinking, okay, what's going on in your nose? Yeah.
Mm-hmm. You have your patients who are like, I just can't have anything touching my face. I was a tanker in the Army and everything bad happened. And that's a special population, the veterans, and they deserve special consideration. Then you have other people who it's inconvenient. My partner makes fun of me. I'm dating. I don't want to wear a CPAP, something like that. And then you have people who say, it's just blowing it's just blowing on my face and it's blowing so hard. And it makes my nose dry and it hurts and it's just blowing so hard and that thing has to be so tight. That last one is the one who I'm really looking at their CPAP machine's compliance report to see what type of pressures is it blowing. But a lot of times those people aren't using it. They haven't used it for years. I don't have access to that. That's the one where I'm very aggressive in treating their nose.
Will they also report a lot? Will they also say like, oh, my nose is really stuffy. I can't breathe through my nose well, or not necessarily?
I think so. There's this whole thing with nighttime nasal obstruction. I breathe okay during the day, but then when I lay down, I can't breathe through my nose gets stuffed up. And there's certainly an association with that and mouth breathing. And mouth breathing changes the dynamics of the jaw and the tongue and the pharynx. And, there's data that treating the nose alone will not cure OSA. However, in my practice, anecdotally, I find that treating the nose, especially in mild OSA, can allow people to keep their mouth shut. And keeping their mouth shut can make very big dynamic changes in the pharynx.
I concur. I think with mild OSA, it can be curative, but maybe that's what you're saying, Ashwin.
Yeah.
Because then they can shut their mouths and have the normal aerodynamics of sleep.
So is that a question you asked too about mouth breathing? Are you mouth breathing during the day or when you're sleeping, or not necessarily?
I don't really care. This is my pet peeve. So the patient I'll set them up for CPAP and they'll go to the DME company, the durable medical equipment company, to be set up. And the DME company will ask them, are you a mouth breather? And if they say yes, they'll set them up with a full face interface rather than a nasal interface. The nasal interfaces have been shown to have lower pressure requirements, better adherence, and overall predict better long-term success than full face interfaces. My personal belief is that if you have sufficient airflow through your nose, that you'll shut your mouth. And when your nose is obstructed, that's why you open your mouth. So even somebody with nasal obstruction who we haven't treated yet, some of those people, if you put the CPAP on them and it forces air through their nose, it's not great. The pressures are too high, dries out their nose and all that, but they'll shut their mouth even though they were a, quote, mouth breather before. If you put them on a nasal CPAP, they'll shut their mouth.